Did you know that plantar fasciitis is the most common form of heel pain, and that 1 in 10 people will suffer from it throughout the course of their lives? Stay tuned to find out more in this video. Make sure you subscribe and hit the notification bell for more content like this, and let's get into this video. So what is the plantar fascia? The plantar fascia, also known as plantar ponderosis, originates in the posterior medial aspect of the calcaneal tuberosity. It then extends across the base of the foot up until it splits and inserts into the 5 metatarsal heads. The plantar fascia is a force absorber in the foot, and it also helps to support the medial longitudinal arch. So let's now get into what plantar fasciitis is. Plantar fasciitis is a degenerative condition which affects the fibres of the plantar fascia. These fibres appear to be irritated by hard surfaces, high training loads and high training volumes. This can be down to sudden increases in training load or activity level. These factors can then cause a secondary inflammatory response in the foot, which can then cause the pain to begin. The plantar fasciitis often appears worst when waking up after a long sleep, after a long duration of being sat down or stationary, and then trying to wake up and walk for the first time often causes significant spikes in pain levels in the foot. The pain is often sharp to begin with, but then eases after a bit of light activity. So what may cause plantar fasciitis, you may ask? Excessive BMI appears to be a significant risk factor for plantar fasciitis. Excessive periods of activity appears to be a risk factor, as this causes an overuse reaction of the stretch-shorten cycle. There also appears to be a high risk factor for the non-athletic population who have a lack of dorsiflexion. Sedentary people also appear to be at risk, and there also appears to be a risk for military personnel. There are also some associated risk factors for plantar fasciitis: excessive running and loading, tightness in the foot and calf musculature, leg length discrepancy, pes cavus, which is a high arch, pes planus, which is excessive pronation of the foot. Again, we've mentioned decreased dorsiflexion, occupations requiring long portions of walking or standing still, and also being sedentary. So testing wise for therapists, there's often going to be a mixture of subjective and objective indications that's going to indicate plantar fasciitis. There's often going to be pain at the origin of the plantar fascia. The patient may describe pain when waking up or after a period of inactivity, then walking for the first few steps, and this pain will often decrease with activity. The patient may describe decreases in pain during activity, but then it returns at the end of the day. There will often be pain with spikes in increased activity level. And when the therapist performs passive dorsiflexion of the metatarsal phalangeal joints and fixes the foot, this will often reproduce symptoms. The patient may also get a positive indication with the windlass mechanism. The patient may occasionally get pain actually into the arch as well. There is often no need for imaging except to rule out stuff like fractures of the foot. So on the lines of differential diagnosis, a differential diagnosis for plantar fasciitis could be a calcaneal fracture. A calcaneal fracture can be ruled out using MRI. There will be a sudden impact mechanism which was high force, and the patient would not be able to wait there post-impact. So now let's move on to some treatments and guidelines of how plantar fasciitis should be treated by therapists. Treatment should always have a conservative factor for at least 12 months, as 80% of cases will heal within this time. Activity management plays a key role in the management of plantar fasciitis. Ice massage seems to have some strong indications for the early stages. Depending on the severity in the patient, it might be beneficial to use crutches in the very early stages. Plantar fascia stretching may be more beneficial within the first 8 weeks when compared to Achilles stretching. Your therapist should be able to design a calf strengthening program to implement during the management of plantar fasciitis. This training should be dictated around the patient, as each case is not the same. There is strong evidence to support the use of orthotics, however, the patient may not be able to tolerate orthotics during the early stages. Addressing any concerns due to biomechanics should be addressed early and is vital to the success and management of plantar fasciitis. Taping has some moderate evidence to support the use for those with excessive pronation within the first week only. There is conflicting evidence to support the use of night splints to put the foot into dorsiflexion. This has been used to decrease pain, however the effects are not much more than this. There is no evidence to support the use of electrotherapy. Injections when guided via ultrasound are advocated, but only as a last resort, where the patient does not improve. If the patient shows no signs of improvement after a year of conservative treatment and after the injections, then it is time to consider surgery. Now let's end with a couple of interesting facts. So as we said at the start, plantar fasciitis is the most common cause of heel pain in adults, affecting 1 in 10 of us throughout our lives. Women aged 40 to 60 appear to be most at risk. Reoccurrence is most common in recreational and elite level runners. The references used for this video are attached in the description below. Have you ever suffered from plantar fasciitis? Let us know in the comments below, or what type of heel pain you've ever suffered from. Make sure to follow our Facebook, Twitter and Instagram in the description below. Check out our website, ultimaterecovery.co.uk, and make sure to like, subscribe and stay tuned for the next video.